Good afternoon, everyone. My name is Dr. Sanjay Prabhu. I am a radiologist at Boston Children's Hospital, and I will be discussing ultrafast imaging protocols. Among my disclosures, I serve as a medical legal expert witness, but none of the cases are related to the current presentation, and I have no relevant financial relationships with any commercial entities mentioned in this presentation. The objectives of the talk are to discuss the evolving definition of what we mean by ultra-fast MRI protocols, talk about some use cases for rapid sequence MRIs as this stands today, talk about some pitfalls and limitations of these studies, and then discuss the need for a true multi-sequence ultra-fast MRI, which will become the future of all MRI brains and spines, in my opinion, and technical considerations that can help us get to this dream, and then finally clinical examples of these ultra-fast MRI protocols being used in practice currently. So the word rapid sequence MRI, quick brain, fast brain, ultra-fast MRI has been used primarily in the last few years to describe the axial, coronal, and sagittal T2 haste images performed, especially in patients with shunt-dependent hydrocephalus in lieu of CT. And the idea is to avoid radiation, avoid sedation in young uncooperative patients, and specifically not as a substitute for a full brain MRI, as was the case made in most reports for these studies. But over time, patients have been imaged for conditions other than hydrocephalus, for example, macrocephaly, intracranial cysts, etc. But most of these studies in this area suggested that radiologists should be aware of limitations for depiction of venous sinus thrombosis and bleeding and other subtle abnormalities. And here, however, over time, many radiologists have been using it for conditions ranging from follow-up extraaxial hematomas, post-op studies, to altered mental status as a screening study for patients with brain anomalies in mild traumatic brain injury, abusive head trauma, and first-time seizures. Here's an interesting case of a child with a large head and developmental delay whom we imaged and got this initial scan. And this was a patient with Alexander disease who we saw had a very abnormal white matter and required a full brain MRI subsequently. With this evolving use, radiologists started looking at these scans, and as we have experienced at Boston Children's, other centers have found the same limitations of these studies in that it's low sensitivity compared to standard MRI for intracranial traumatic pathology, especially in patients with abusive head trauma. And there's a case made that these studies should be used carefully and with the appropriate guidance to the ordering providers so they know the true sensitivity and specificity of this valuable technique. The potential pitfalls of fast MRI range from missing small subdural fluid collections or characterization of these collections wrongly because you only have T2 images to look at. Parenchymal lacerations or subcortical tears may be missed. Subarachnoid blood is particularly hard to recognize. Focal cortical dysplasias can be very easily missed on these studies. And then malformation cortical development, for example, polymicrogyria, can be hard to see on these studies. And cystic tumors can mimic benign cystic lesions and and vice versa. And leptomeningeal disease, like tumor infection, can also be hard to recognize and quantify on these studies. And small tumors and venous sinus thrombosis may also be missed. Here's an example of a child who came in from an outside center, had epilepsy surgery in the past, and was complicated by subdural collections. So we went ahead and did what we call a vent check MRI or a rapid brain MRI. And here you can see there's this area in the cisterna magna, heterogeneous looking area, which at first glance looks as just CSF space, but it looks heterogeneous. So we went back and had a look at the outside studies, which showed diffusion restriction in the lesion. And this, of course, is a epidermoid of the cisterna magna. Another case, which is a solitary case here, is a patient with was post-op after a shunt revision, had a history of a third ventricular parasitic acidostoma, and on post-op day 1 had a very nice dark-looking venous sinus. On day 8, it's slightly gray. By day 10, you can see that there is a gray signal within the superior sagittal sinus, and by day 16, it's expanding the sinus. And on day 17, by the time we do a full MRI, you can see the T1 intense thrombus filling the vein. So in the initial scans, this was hard to recognize. One was missed. However, the patient did not come to any harm. What we really need then is a non-sedated full brain MRI in young or uncooperative or older kids with a more spatial resolution comparable to routine MRI, with this imaging time of 5 to 6 minutes or less. And institutions like have also tried this. For example, the MGH, the Mass General Hospital, and our own institution, we have tried these fast sequences to replace the conventional protocols in motion-prone inpatient clinical settings. And also other institutions from, for example, Korea, have used these 1 minute ultrafast brain MRIs to compare them with routine brain MRIs. But the problem with these is the spatial resolution is not as good as the routine brain MRI protocols, as these authors did acknowledge in both studies. So to improve signal to noise ratio, we have to look at the field of view, the slice thickness, the matrix size, the number of echoes, and receiver bandwidth. And it's a trade-off between spatial resolution and this SNR. The longer scan times means better SNR, but it also means it increases the image noise. So the motion is very challenging in patients with the younger patients on longer scans. Traditional solutions proposed are parallel imaging and compressed imaging. And parallel imaging has a big disadvantage in that as you increase the acceleration factor, there's signal loss, as you can see here. Acceleration factor 1.25, the signal loss, the signal the signal is about 0.9, and the signal loss significantly gets worse as you increase its acceleration factor. Compressed sensing exploits this sparsity of MRI in that most MRI images are sparse after transformation into appropriate domain. But the limitation of compressed sensing MRI is that manual design methods are used to exploit the sparsity, and these are not efficient. So the newer solutions proposed are deep learning solutions, and these are fully automatically and fully exploiting the available data information, and they can recover the lost information using prior knowledge. This was first described in 2016 by Wang et al. Using a three-layer CNN, and since then, subsequent studies have published more sophisticated, robust, optimized deep learning models for image reconstruction. The image inputs in these cases are low-level features are the edges, contours, and texture of the images, whereas the high-level features are the semantic features, that is the image context as we perceive them, that is basically the formed image. MRI reconstruction produces high-quality images from sampled case space, and the conventional reconstruction methods produce high-quality images using the higher sampling frequency, which requires us to increase the acquisition time. As you undersample, you get imperfect image reconstruction. In the deep learning models, the input is in case space or image space, and the reconstruction model helps us to create a high-quality output image. There are lots of commercially available applications now on the scanners, and we use some of these in our practice. So here are some clinical examples. So here is a patient who had an unconventional Axel T2 acquisition time of 3 minutes, and just compares to a acquisition time of 47 seconds. And I would say this deep learning-based reconstruction image is better and has a pixel size of 0.35 compared to 0.44 on the first one. Similarly, here's another patient with a blade sequence used to minimize motion by 1 minute 54 seconds, and this is out of our faster sequences. And if you compare this to 47 seconds, this image again looks nicer, has lower pixel size of 0.35 millimeters squared, and acceleration factor of 3, and you still have good signal to noise ratio. The flare images, again, you can reduce them in time acquisition, not as much, but again, acceleration factor of 4 will still maintain most of the signal. The ACR requirements are for a 5 millimeter scan with a recommended resolution of 1.2 millimeters squared. It is possible to easily beat that with the 5-minute scan in total for a brain, and a 6-minute scan in total for a spine if you use these parameters using deep learning based sequences. The other approach is to use synthetic MRI and acquire a 6-minute image and then produce multiple contrast, as you have probably heard from other presenters in this conference. However, this has a long acquisition time of about 6 minutes, and if there's motion on one sequence, then obviously it affects all the other ones which are derived. So these are an example of synthetic MRI that we have performed in our institution, compared with our stealth sequence, which is 1 minute 6 seconds long. So again, our fast sequences still compare very well. However, there's a new innovation in that the deep learning-based reconstruction is coming into synthetic MRI, and these can allow us to acquire 3D acquisitions with about 40% reduction in the imaging time using deep learning-based reconstruction. And this will be another advantage to get a 3-minute sequence and get multiple acquisitions. In summary, we need to define ultrafast MRI better and educate our clinicians of the limitations. We need to develop new protocols that enable truly ultra-fast multi-sequence MRI. And then we want to use deep learning imaging reconstruction in the future. This is going to be the future, and which is now possible to acquire a full brain and spine MRI in 5 minutes or less. And we need new building codes to reflect these rapid sequence MRIs. And faster scans will obviously mean we'll be expected to read more scans in the same amount of time or less. Thank you very much.